Hi friends, today's daily dose of MCQs. So I'm here with the first question. A 37-year-old woman with immune thrombocytopenia failed to respond to corticosteroid therapy. So she was planned for splenectomy. The question is, what is the optimum time for pneumococcal vaccination in this patient? So here is a case of a patient who is having a disease of immune thrombocytopenia and she failed to respond on the corticosteroid therapy. Now we have to do the splenectomy. She has been planned for splenectomy. So what is the time for such a patient to administer pneumococcal vaccination? The options are like 1 month after the surgery, 1 month before the surgery, or 1 week after the surgery, 1 week before the surgery, or it is perioperatively. So the answer for this question is option B, 1 month before surgery, because it is recommended that at least 2 weeks before the surgery that it should be administered. So pneumococcal vaccination is done at least 2 weeks before the surgery as per British Committee for Standards in Hematology. So this question is a simple question which is a fact and which is based on a information which is like British Committee of Standards in Hematology recommends it is at least 2 weeks before the surgery we administer pneumococcal vaccination. So in the options we have at least 1 week before, which is a wrong option. We have this one as a wrong option as it is only 1 week. It is never after the surgery. It is never after the surgery and it is not peri-operatively. So the option B is the correct answer. Okay. Now coming to the second question, a 30-year-old man had moved to UK recently. So his doctor informed, he informed his doctor that he had maturity onset diabetes of young. So he has the history of maturity onset diabetes of young. So in this case, what is the most important factor that suggests the correct diagnosis of maturity onset diabetes of young? So the question's theme is what if the question's diagnosis is given as maturity onset diabetes of young? So what is the factor which suggests it is MODI? So the options are a BMI of 30, a poor response to glipizide, a strong family history of diabetes mellitus, and recurrent episodes of diabetes ketoacidosis. Plus option E is X-linked recessive inheritance. So in this case, the option for this question, the answer is the correct diagnosis which gives us MODI is option C, a strong family history of diabetes mellitus. Okay, so we'll come to the explanation once. Because maturity onset diabetes of young is suspected when there is a young person who is having a strong family history of diabetes mellitus. So a person with a strong family history of diabetes mellitus coming in a young age with the history of diabetes mellitus, then the answer is most suspected to be MODI, maturity onset diabetes of young. So that was the question. It was also a simple question which is a fact on to be known. Okay, now coming to the third question. A 17-year-old girl. So this is a typical case of a young adolescent girl, 17-year-old girl who came with complaints of single painless enlarged cervical lymph node. So it's a just solitary single. It is painless. Okay, and it's cervical. So this single and painless cervical lymph node, and she was investigated with X-ray, and enlarged mediastinal lymph nodes were seen. So there she was seen with enlarged mediastinal lymph nodes. So she was asymptomatic. That is the another point we should note in this question. So the young lady, the young girl who presented with a single painless enlarged lymph node, she is asymptomatic, and her X-ray, chest X-ray showed enlarged mediastinal lymph node. So question here is, what is the most likely diagnosis? The options here are angioimmunoplastic T-cell lymphoma, option B extramedullary plasmacytoma, option C is follicular B-cell non-Hodgkin lymphoma, the fourth option is Hodgkin lymphoma, and fifth option mantle cell lymphoma. So the answer for this question is, this is just a typical question where it shows like a young lady, young girl who is asymptomatic, means otherwise she is apparently normal, but she presented with a single painless cervical lymph node, and X-ray shows enlarged mediastinal lymph node. So in this case, we should note that this girl has an enlarged mediastinal lymph node, which is always pathological. So this is pathological. Okay. So we have to see the options first. So by seeing the options here, the correct option for this question is option D, Hodgkin's lymphoma. So why? We'll come to the explanation. Because the history makes clear that the patient is an adolescent female, okay, with cervical and mediastinal lymphadenopathy. So this is the first point we should note in our mind. So she has no other described symptoms, so that no other described symptom means she is otherwise well. So the presence of mediastinal lymphadenopathy should be considered pathological, okay, so that is pathological. So the most common malignant diagnosis in this history, in this age group, so we should consider the age of the patient and the history. The answer is Hodgkin's lymphoma. Okay, the condition is most commonly present in the neck and mediastinal lymphadenopathy, and peak incidence is during adolescence. So peak incidence is adolescence, and most patients may be asymptomatic. So this all this all together gives us the clue that the patient has Hodgkin's lymphoma. Okay. Now coming to the other options of this question, if we come to the angioimmunoblastic T cell lymphoma, which is uncommon in this age group. So that is uncommon in this age group, okay, and would classically present with more widespread lymphadenopathy and a rash. So there can be a history of rash and a widespread lymphadenopathy, so that we rule out angioimmunoblastic T cell lymphoma has been ruled out, okay, which is widespread lymphadenopathy, which is presenting with a rash often. Now, extramedullary plasmacytoma is also unlikely in this age group, okay, and classically present with lesions in the upper respiratory tract and can be presented as oropharyngeal infection. So there can be lesions which has lesions in the upper respiratory tract, and most probably the lesion may be in the oropharynx, maybe superadded with some infections or some other causes, but usually the lesion is in upper respiratory tract, and this is not unlikely in this age group, so we rule out the option extramedullary plasmacytoma. Now the option other one is follicular B cell non-Hodgkin's lymphoma. Again, coming to the option, it is much less likely than Hodgkin lymphoma, which here we should note that it is less likely, okay, which means among the options Hodgkin lymphoma is the best answer, although asymptomatic lymphadenopathy can be seen in follicular B cell non-Hodgkin lymphoma. As we have the option Hodgkin lymphoma in our options, the best option is Hodgkin lymphoma. And final option, mantle cell lymphoma. Mantle cell lymphoma is not the option because it is not seen in this age group, plus would present with a more widespread lymphadenopathy and has option with there can be a chance of lymphadenopathy with splenomegaly. So with all these conditions we rule out all other options, but we have the answer as Hodgkin lymphoma. So that was today's discussion on, first we had a question from hematology, that was, when do we do a pneumococcal vaccination if a splenectomy was planned for a patient with immunocytopenia or some other thrombocytopenic causes. Okay, so that was 1 month before the surgery. The recommended time period is less than at least 2 weeks before the surgery. Okay, now the second question was about maturity onset diabetes of young. This was a question from endocrinology. So this again, the option is very simple. A strong family history of diabetes mellitus is the one which suggests mostly for MODY. Okay. Now the third question is 17-year-old came with a history of single painless enlarged cervical lymph node which was asymptomatic, and the chest x-ray showed enlarged mediastinal lymph nodes, nothing other. She was apparently normal, and but we consider this enlarged mediastinal lymph node to be pathological, and among the options we rule out, though we had, there is a chance of asymptomatic patient with cervical lymphadenopathy can be seen in the patients who has follicular B cell non-Hodgkin lymphoma, but we rule out this option because there is a high chance of Hodgkin lymphoma. Because this option is in this question, we prefer this is the best right answer. So that was today's discussion. Thank you for watching.